I'm Dr. Parish Sedghizadeh, DDS MS. I'm an assistant professor of clinical dentistry at USC School of Dentistry and the director of the USC Center for Biofilms, which is a microbiology laboratory at USC. I'm a boarded oral and maxillofacial pathologist, and I have extensive training in radiology, pathology, and oral medicine. So I'm going to talk a little bit today about cone beam CT and applications in dentistry, specifically different disciplines of dentistry. So let me go ahead and get started. So cone beam computed tomography is increasing in significance in the field of dentistry right now. There are a lot more applications that it's being used for, and it's becoming standard of care. So I'm going to discuss a little bit about what a cone beam CT is. So here's an image of a cone beam CT, a schematic, and this is conventional CT. So comparing conventional to cone beam CT, conventional CT works in slices. Okay? So you get slices through the tissue. Cone beam, as the name implies, is a cone through the tissue, and it's basically radiographic technology, and they're very similar, but the applications of and the uses for cone beam CT are better in dental use, as you'll see, and I'll show you examples of that. So with cone beam CT, here's some examples. This is what's called a hard tissue window and a soft tissue window in an axial cut. So this is a slice in a conventional CT. And it gives you a lot of information about what's going on. Here's the maxilla here and the maxilla here. The soft tissue window allows you to see a little bit better the soft tissues, like the muscles and the glands and the other oral soft tissue structures. And then now here's a coronal and a sagittal cut. So 3 different dimensions. So what a CT is doing is basically giving you an X, a Y, and a Z axis, an axial or coronal or sagittal cuts. And then putting those cuts together, you can reconstruct 3-dimensionally what you're actually seeing. So it's very important for phenotypic characterization and allowing you to see structures that you can't see. Cone beam CT also gives you that X, Y, Z, that 3-dimensional reconstruction, but it does it by acquiring it through a cone. And here you can see as it scans, it's a cone-like beam of X-rays, and you acquire this 3-dimensional image. So you can actually, through the software that's used for most cone beam CTs, you can do X, Y, and Z. You can do slice reconstruction. So you can look at coronal, axial, and sagittal planes. Okay, the radiation doses, I like to just mention a little before we go on here, because a lot of people ask, what about radiation? It's only 36.3 microsieverts. So let's compare this. What does that mean? As far as dosing goes, a complete mouth series, an FMX as we traditionally call it, is 33. So it's very similar to getting an FMX. If you look at some of these other modalities, like panoramic radiography is pretty low, 7 to 11. Conventional tomography is 25 to 189, depending on the unit. And computed tomography is 580 at least, or 480. And so it's not as much radiation as conventional CT. And it's very similar basically to an FMX and slightly more than a panoramic radiograph. But the importance of it is that in one scan, you get most of the information that you need instead of doing multiple images, like taking a panoramic and an occlusal and an FMX, or certain select bite wings and periapical images. You do one scan and you get most of the information that you need for the applications that it's being used for right now. Like most X-rays, you get a lot of information about density, and density is very important. So the most radio-opaque being here and the most radiolucent being here, you can tell from these images with pretty good precision whether something is metallic, whether it's a restoration or a cement, whether it's enamel, dentin, or cementum, cortical bone versus trabecular bone, calculus, soft tissues, and then going all the way down here to fat and air. Okay, so that's why the sinuses, for example, appear very black, because they're very radiolucent. They're empty space, basically, with air in them. And then metal restorations appear very radiopaque. Okay, so the density is very important. And so the applications of CBCT are increasing right now in dentistry. And pretty soon it's going to become the standard of care for radiology and for radiographic diagnosis and treatment planning. And not just digital treatment planning for implants, but for a lot of disciplines right now. The applications currently that are very significant are in implantology, orthognathic treatment and surgery, orthodontic treatment planning. At USC, for example, the orthodontic department really doesn't use lateral cephs anymore or any of these other images. They pretty much take one cone beam CT, and that volume allows them to do all the reconstructions that they need to do. And it's amazing for treatment planning for before and after, because there's software that you can show the patient, this is what you look like now, and this is what we plan to do, and this is what your facial profile and your teeth are going to look like afterwards. So it's really profound for treatment planning. Orofacial pain and TMJ, this is becoming standard of care now. Open and closed mouth acquisition of images to examine the joint structure for a lot of degenerative joint diseases and orofacial pain related to TMD or temporomandibular disorders. Evaluation of trauma, very profound utility there. And then obviously in oral maxillofacial pathology and oral maxillofacial radiology. Oral maxillofacial radiologists are more and more using this cone beam CT. It's becoming their primary bread and butter, if you will, of what they're doing all the time and what they're looking at and how they're taking technology forward in radiology is focused predominantly now on cone beam CT. So with that in mind, I want to go over some exemplars of some of these applications so you can see what kind of cases that we see and what the utility is. Now, orthodontic and orthognathic treatment planning is really one of the biggest areas that cone beam CT is being applied for right now. It's a standard of care and will soon become the established standard of care. So for example, you imagine that you do a lateral ceph and you do tracings. You can do all that now from a cone beam CT. You can see the position of impacted teeth. You can treatment plan orthodontic procedures. And here's an image here where it shows you 3D images, axial of impacted right maxillary central incisor, and transposition. And you can see that here. So with these nice three-dimensional reconstructions, you can see exactly where teeth are. And the different planes, the coronal, the axial, and the sagittal, allows you to tell exactly where teeth are, buccally, lingually, inferiorly, superiorly, and in relation to each other and other structures. For dental implants, we know that for implantology, oral surgery, dental implants, periodontists, they're using this routinely, and this is becoming more and more the standard of care. It is pretty much the standard of care for treatment planning, digital treatment planning, for implantology, for implant placement. Here's a panoramic showing some radiographs. Here's a coronal, panoramic radiograph. Here's a coronal and sagittal cut. And then here's a sagittal image, and it shows extensive mucosal thickening in the sinus associated here with these implants. So not just for implant treatment planning, but for following implants and for sometimes pathology related to implants. For example, here you can see a very radiopaque structure in the sinus with a bit of a sinus reaction, a cloudy haze to the sinus around it. And when you get another view of that, you can see that there's actually an implant in that sinus. So there's a lot of utility for not just implant treatment planning and placement, but following up patients with implants or for implant failure to figure out the different causes or differential diagnosis of what might be going on. Here's an example of TMJ Joint Imaging. Here's a corrected sagittal and axial scout and a corrected coronal showing the joint here. You can see that nice joint in the temporal fossa. And here's some pathology associated with this. This is what we call osteocyte formation right here, loss of the superior cortex, definition, and subcortical sclerosis. This is very characteristic of degenerative joint disease or osteoarthritis. And since a lot of times we see these in images and sometimes we see them incidentally in implant digital treatment planning images that we see, because this is an older population, many of them that are getting implants are getting these kinds of reconstructive procedures. And it's not unusual to see osteoarthritis or degenerative joint diseases. So the orofacial pain and TMJ clinicians are using this more and more in open and closed mouth positions. Cone beam CT is also very useful for trauma evaluation. This is a 47-year-old male who sustained a fall on an icy sidewalk. And here's the left joint and the right joint. And you can see the difference here. The left joint is nicely in its place in the temporal fossa. And this is a displaced right condylar head of the right side from that trauma. And you can see in these images here that the condylar head is displaced. It's anteriorly and inferiorly displaced right here on these images in the glenoid fossa and the closed mouth position. So a lot of utility. And with 3D reconstruction, you get a really good appreciation of what's going on with these. In this 3D reconstruction, you can actually see fracture and overlapping of the bones there. And this would be something that may be very difficult to pick up on a panoramic, or some of the more conventional imaging studies that we use in dentistry. Here's an example of a 16-year-old male with a lost third molar during surgical extraction. And with these reconstructions, you can see in these different planes, we can figure out exactly where the tooth is. So with that X, Y, and Z axis, or reconstructing, you can get to the point of exactly where is this thing three-dimensionally. And you can just tell from the X, Y, and Z axis exactly where this is. And you can also do reconstructions to show where these are by stripping away some of the tissue and bone and pinpointing exactly where this tooth is. So this lost tooth is actually located in the left infratemporal fossa anterior to the coronoid process. So it's great for anatomic identification, especially during things like surgical extraction where you lose a tooth. This is where we were able to localize a broken elevator in a 21-year-old female, and you can see exactly where the little tip is right there. And the axial coronal and sagittal images nicely show a broken elevator tip at the base of the mandibular left third molar socket. And you can see there's a bit of perforation there. So that gives us a nice localization of where it is and lets the surgeon know where to go to retrieve that. And then obviously in oral maxillofacial pathology and radiology, there's lots of applications for this. The American Board of Oral and Maxillofacial Radiology and the FDA have recommendations and guidelines for radiology, and they don't recommend taking any necessary images for radiographic diagnosis of occult disease, as they call it. So what they mean is you don't just take an x-ray to look for something like pathology. Okay? But if you've taken the x-ray, if you've taken the radiograph, if you have a volume of cone beam CT and there's pathology on it, potentially you're medical legally responsible. There is some liability there because it's evidence. The image exists and the data is there. So this is very much like when you go to see a physician. The physician doesn't say, okay, before I see you, I'm going to just take a whole body CT and a whole body MRI, and then you have a seat, and then I'm going to see you. What they do is they see you first, they do a risk assessment and determine, okay, is there something that may be going on in structures that I can't evaluate or that would be better evaluated by taking this imaging study? So this is the approach in medicine, and it should be a very similar approach as the FDA and the American Board of Oral Maxillofacial Radiology suggest for dentistry, and that is their recommendations, that you don't just take x-rays to look for things that can be there, but once you've taken them, it's very important or incumbent upon you to evaluate them and look for anything on them. So we don't just look at the area of the implant and trace the nerve and say, okay, this is all we're looking at. There's a whole volume and there's other information in areas that we need to look at. And so this becomes very important. So we don't take images for occult disease, but once the image is taken, we need to look for it. So this is a panoramic radiograph that shows this ill-defined to relatively well-defined radiolucency associated with this impacted tooth. And when we do these panoramic reconstructions with cone beam CT, we get a lot better, closer images. And the good thing with the cone beam CT is you can do a lot of, with the software, there's a lot of image adjustment that you can do. So you can do a lot of magnification, change the brightness, the contrast. You can get really close. You can do certain windows, meaning you can get better, closer look at some of these images and areas of pathology and lesions and really be able to tell what's going on. So this gives us a nice idea. When you look at the panoramic, it doesn't give you a sense of really the extent of this lesion, but when you look at it here, it gives you a lot better notion of the extent of the lesion. And then here's different axial and coronal images that show this radiolucency here and the extent of it. And here. And you can see that there's evidence of cortical perforation right here. So compare the normal cortex on this side, lingually, to the lingual cortex here. You got some loss of cortex there. So you get a lot of information about what these lesions are and what they're doing. And so this was actually a donogenic keratocyst, just in case you were curious. Here's a case of a root canal, patients having symptomatology in that location, some pain. X-rays were taken, but look at what you can tell from the cone beam CT. There's this large lesion. It's very hydraulic in nature, and these coronal and sagittal images give you a nice image of what's going on here. It's a very hydraulic radiopaque mass displacing the left maxillary sinus floor. You can compare this side to the other side here, and it's consistent with a radicular cyst. So this is the kind of information we can get from this as far as pathology goes. This is a 41-year-old male with right-sided palatal swelling clinically. So a panoramic was taken. It really didn't show anything as far as the bone. And the palatal area of a panoramic radiograph is not the best diagnostically. The midline structures on a radiograph, there's superimposition from the spine, so they're not ideal for diagnosis in the midline of a panoramic radiograph. So that didn't really show much as far as the palate goes. But when we took the cone beam CT, you can see a nice kind of well-defined to ill-defined destructive radiolucent lesion of the palate involving the sinus, with infiltration into the sinus there. And when this was biopsied, it was a mucoepidermoid carcinoma. So the cone beam CT can really help you with diagnosis, differential diagnosis, surgical treatment planning, how to approach this, where's the epicenter of this lesion, where's the best place to sample this lesion to make sure we get a representative sample. This is a 52-year-old male with intermittent sharp facial pain, and you have coronal and axial images here, and they show basically mineralized tissue bilaterally in the neck area on these images. So the good thing about these images is that we don't just see the jaws. It's not just the maxilla and the mandible, which is what you think of mostly when you do these for digital, dental, implant, treatment planning. You get this nerve tracing and you figure out, okay, what's my angulation and where do I need to place this implant? But you get a lot of other structures actually also that are acquired from this image in this volume. And most of the time the spine is actually there and the neck structures are there. So besides the brain, it's actually really a head and neck imaging modality. You're not getting a brain, it's not like a brain MRI or a brain CT, but you're getting a lot of head and neck structures, basically from the eyes down to the neck. And so in this case, we see in the soft tissue area of the neck, here's the spine, here's the mandible, and these are mineralized structures that we're seeing. And in oblique reconstructions, we can see that they're actually pseudo-joint formation and calcified stylohyoid ligaments. This would be something you could potentially see in Eagle syndrome, or you can just see this incidentally in a lot of these images. And sometimes this is associated with pain or pain upon churning of the neck, and the patient doesn't even know that's the reason that they've had this. Or it can be just incidental and asymptomatic. So this is a very nice case that shows what those calcifications are. And in the 3D reconstruction, you can, with the soft tissue stripped away here, you can see these nice joint stylohyoid ligament. So these are things that you can see. Here's a case of pansinusitis. You see the sinuses are basically cloudy. One's completely obliterated for the most part and the other partially. So a patient that may be complaining of sinus symptoms or allergies all the time or headaches, sinus-related headaches, these can give you a lot of information. This is a sinus mucocele or an antral pseudocyst. This is not uncommon to see, and a lot of times for implant treatment planning, clinicians want to know, okay, I see this thing here, what do I do with this? Can I put an implant there? And of course, all the other things still apply. Is there enough bone? Do you need to do a sinus lift? But this won't affect your sinus lift because we can tell you what this is and that the sinus is already basically lifted there. So you can go ahead and do a sinus lift with lesions like this. So there's a lot of information that we can tell you. And here's another view of that showing that nice little sinus mucocele. Here's another case of sinonasal polyps. There's just a bunch of polyps throughout the sinonasal structures there. And this is a case actually of osteosarcoma. This is very anterior in the front part of the nose, and it was just a very firm, nonspecific swelling. And this patient, when we took this cone beam CT, we can see heavily mineralized tissue. And if you look at it, it looks like bone. It looks like the other bone, in other areas that you can see in that slice of the image. And when this bone was biopsied, it turned out to be malignancy. It was a low-grade osteosarcoma. And that's exactly what it looks like. Bone growing in an area, a neoplastic growth of bone in an area that shouldn't be there. This is a nice case where we had a lesion of the condylar head, and you can see it here actually sticking out of that temporal fossa or glenoid fossa. Compare the condyle on the right side, which is normal, to this side, which is actually sticking out. And so this lesion here was biopsied, and this was an osteochondroma. Okay, and you can pretty much make a definitive diagnosis of these on a cone beam CT. It's practically the standard of care for diagnosing these lesions. When osteochondroma is not a very common lesion, but when it happens, this is where it happens. This is a case of kind of ill-defined radiolucency in a patient that had malodor and an ill-fitting denture, and this was going on for several months, possibly even a year or more. And this is a case of osteonecrosis of the jaws, secondary to bisphosphonate therapy. And now a lot of these patients that we're seeing more recently are on these medications for IV cancer therapy, bisphosphonates, or oral like Fosamax, Boniva. And we now know that these bisphosphonates are associated in the pathogenesis of this jaw necrosis. There's a lot of things that can lead to jaw necrosis: infection, steroid therapy, diabetes. Jaw necrosis can be an end result of a lot of conditions, but because of this rise in emerging phenomena and treatment of osteoporosis in cancer patients with bisphosphonates, we're seeing more and more of these bisphosphonate related jaw necrosis. So this is something that you're going to see. You're going to see this in the elderly population because they've been on these medications for a while. You're going to see these in the population of patients that are getting implants, for example. So it's important to know. In some cases, there may be direct contraindications to doing implant placement in some of these patients. So these scans can give us a good idea if there's pre-exposed bone, basically, meaning radiographic evidence of necrotic bone going on before there's actually sequestration or a large advanced lesion in the mouth. Or it can tell us the quality of the bone at an implant site, for example, in a patient that's been on bisphosphonates and will need implants at that site. So keep that in mind. Here's 3D reconstructions that beautifully show the involvement of this osteonecrosis. This is going all the way to the sinus and to the canal in this case. This is a 3D reconstruction from a cone beam CT scan showing a large periapical cyst or radicular cyst in the anterior maxilla with some perforation there of the bone, and this has been going on for a couple of years in this patient. Here's an example of some stones in the soft tissue area of the floor of the mouth. This is where you shouldn't have anything because it's soft tissue. It's predominantly radiolucent. But here we see a couple of round, kind of amorphous-like calcifications or mineralizations, if you will. And these are consistent with stones or sialoliths in the floor of the mouth. Here's a case of an odontogenic keratocyst, or as the WHO classifies it now, a keratocystic odontogenic tumor. Pretty well-defined radiolucency with expansion and thinning and likely perforation of the buccal plate there in the mandible. Here's a case of a Staphny defect. It's a well-defined radiolucency, and these tracings show the nerve here, and then the impression there of the minor salivary gland. A Staphny defect is basically just a depression of the minor salivary gland there in the jaws. Sometimes when it's seen on imaging studies, it's mistaken for being an ameloblastoma or an OKC or some kind of cyst, odontogenic cyst or odontogenic tumor. But with cone beam CT, you can easily see on sagittal cuts that it's just a depression, that it's not actually a radiolucency inside the bone. So it doesn't warrant a biopsy. Sometimes the canal, the mental nerve, doesn't just come out of the mental foramen. There may be actually a loop, and some may call it an accessory canal in the anterior mandible. That can be very important for implant placement. You don't want to be putting an implant in somewhere where there's an anterior loop, and it can loop down, it can loop up. So it's absolutely unique in every individual anatomically. It's not seen in every person doesn't have an anterior loop, but some patients do, and that can be very important to identify. We also see a lot of mineralized structures. And remember, I said the cone beam CT is very good radiographically for determining density. So we see a lot of things that are dense or radiopaque. In addition to a lot of the radiolucent-like things like the cysts that I showed you and the tumors that I showed you, there are radiodense structures that we see, and it's important to know what these are, especially if you're going to put implants in these areas and you're going to do treatment planning or you're going to do orthodontics and move teeth. This is very consistent with idiopathic osteosclerosis, or a dense bone island, what was formerly called condensing osteitis. It's important to know what this is so that you don't think that this is anything more, that you don't think this is a bony tumor, and that it's okay in cases like this where it's just a dense bone island to go ahead and do treatments like implant placement and things like that. Here's another example of a large area of dense bone or enostosis, or what we call idiopathic osteosclerosis. Here's a pretty well-defined unilocular radiolucency. It looks like there may be perforation buccally and lingually. This was a central giant cell granuloma of the maxilla. So a lesion that's very interesting from a pathologic perspective and would be very difficult to diagnose. This could just mimic any kind of odontogenic cyst, or odontogenic tumor like an ameloblastoma. So biopsy in this case is warranted based on this imaging study for definitive diagnosis. And this is a very interesting case. This is showing, here's the normal mandible in this area, and here's the abnormal side. And what we see is what's called a hair-on-end morphology. So what's happening here is there's basically blowout or spiculation of the bone in that area. There are not a lot of lesions that cause this look. And one of them is osteomyelitis, an infection of bone, but generally that would be pretty symptomatic at this point where it would be showing this. Another is metastatic disease. And when metastatic cancer happens, it's not uncommon for one of the locations to be the posterior mandible. It's one of the sites, for unknown reasons still, there's hypotheses about this, but for unknown reasons, it's one of the sites that's not uncommon to get metastases. So as dentists and specialists in dentistry, like pathology and surgery, this is one of the common sites that metastatic lesions present to the maxillofacial regions. So when you see a weird lesion of the posterior mandible, and it has this hair-on-end look, or it's an ill-defined ragged radiolucency, these are kind of red flags that go off for clinicians. And they may or may not be symptomatic. In this case, this was asymptomatic, and this was the first diagnosis that this could be metastatic disease. And when this was biopsied, it actually was consistent with metastatic prostate cancer. The patient was thought to be in remission, but with this identified, it was found that they were not. So let me just conclude by saying that although cone beam CT technology doesn't replace conventional intraoral views, in many cases we still use FMXs, we still use bite wings, we still use panoramic radiography, but its clinical utility when advanced imaging is required, make it an ideal choice for investigations in dentistry, particularly dental implant placement, digital treatment planning, follow-up for dental implants, orthodontic and orthognathic treatment planning and treatment follow-up, TMJ evaluation, non-odontogenic structure evaluation, like soft tissues in the head and neck, where I showed you things like calcified structures. You can see calcified atherosclerotic plaques, calcified ligaments and things like that, calcified lymph nodes like you would see in scrofula, TMJ evaluation, especially for TMD disorders and joint degenerative diseases, trauma, and oral and maxillofacial pathology and radiology. This is becoming more and more the primary bread and butter, as I said, for oral and maxillofacial radiologists. This is what they're using and this is what they're doing. The standard of care is shifting to cone beam CT, and that's going to happen. It's happening now, and it's not going to be a very long time before in dentistry and dental-related procedures and treatment planning, it is the standard of care over any other imaging studies. And why, if you think of some of the reasons for that, is the radiation that you get from it in one volume is very low. So if you just do one cone beam CT, that's your baseline imaging for anything you need for the patient. Right now we don't do it because it's not as sensitive and specific for caries detection or periodontal disease detection, but that's changing right now because oral radiologists are on the cutting edge of research in fine-tuning this technology and the software associated with it for allowing us to start looking at things like caries and periodontal disease and pocketing, three-dimensionally and two-dimensionally with these different slices. So it will become the standard of care in the very near future for probably any dental imaging procedure that needs to be done. And then the medical legal considerations are important. As I discussed, once you take these images, whether you're doing it for dental implant placement and treatment planning or orthodontic treatment planning or just to look for a certain pathology because there's swelling or patient has symptomatology, once you take these images, it's pretty much incumbent to evaluate the entire scan and the entire volume. This is how medical radiology works. If you were to get a head and neck CT scan, a medical radiologist wouldn't just look at the area where the pathology is supposed to be. They will look at the entire volume. They'll look at the entire scan diligently and sit there for at least a few minutes and look at the entire thing to make sure everything else looks fine. Does the throat look fine? Do the parapharyngeal spaces? Do the sinuses? Do the eyes look fine? Anything that's in that scan is evidence. It's data. It can be used in court one day. So there are medical legal considerations that exist with these images. So when these scans are taken, there's actually a lot of resources available to you when you have these scans taken, and one of them is that you can actually have these scans evaluated by a pathologist and a radiologist, and they can give you a path report. So they can do a radiographic pathology report for you and look at the entire volume so that you can focus on your implants, and they can tell you whether there's anything else, any other disease or pathology or anything you should be concerned about with these lesions. And if you think of that as far as standard of care and medical legal considerations, having a pathology report in your hand to put that in the chart and for the patient is very nice. That's going to become the standard of care for medical legal reasons. And finally, I just want to say that the potential exists with better sensors, computers, and software technology to aid in caries detection, characterization of root morphology, periodontal evaluation, and any other radiographic need in dentistry. So, with that said, this is probably why we're going to see this becoming more and more the standard of care for any imaging study that's going to be done in dentistry prior to treatment planning or for follow-up for treatment. The technology, as far as the technology goes, one final comment on the technology, cone beam CT units are not as expensive as conventional units. The radiation is not just less, they're smaller. They're what we call more portable. And that's how technology goes. You start with something the size of a room and eventually gets smaller and smaller and smaller. So the technology right now for cone beam CT is very portable. It can fit in one small room in an operatory somewhere, and so it's not going to be uncommon to see, in the next decade, general dentists having cone beam CTs, most orthodontists having them, surgeons are, routinely getting them right now, obviously for implant placement and things like that. So the potential and the impact and the portability of the technology, it is significant, and it's growing, and it's getting better. Thank you.